Okay. Hi, everybody who's joining. I see some familiar names I haven't seen in a while. It's good to see you guys. Or not see you, but see your names, I guess. Susan, I hope you're doing well. I haven't seen you in a while. I assume that's Tim Sutter there.
Hey,
Welcome. Welcome, welcome.
nice to see you too.
Yeah, thank you. You guys doing okay?
Yeah, I'm actually going to retire at the end of this month.
Wow, that's
So this will
exciting.
this will be my last
Congratulations.
seminar with you.
Oh, good for you.
Thank you.
That's exciting news.
It's about time. I'm 69, you know.
Are you really? No way.
Yeah.
Never guessed that. Never guessed it. Well, good for you.
Thank you.
If you want to keep participating, just send me your personal email. I'll add you to the list. You don't have to, but if you want
Okay, well, thank you.
to. It's officially 11:30, but we're going to give it a couple minutes. We've got some people here joining. Hey, John. Hey, Debbie. Good to see you guys. See your names anyway. Hi, Tim. Welcome. All right, one more minute and then we'll start. I think everybody's muted themselves, but if you don't mind, unmute yourself um, just for background noise. We will allow for questions at some point as well. Go ahead and get started. It's 11:32, about to be 11:33, I think. I'm sure people will continue to join, so we'll add them in as they go. But welcome everybody to our annual Medicare seminar. A lot of you have probably been joining us for the last few years about this. And today we are honored to have with us Graham Kimmerer from MFS, from our great friends at MFS. They're great partners with us. And so we're excited to have him. Graham is a senior strategist of business development at MFS. And in his role is basically to help us, help you guys with things like Social Security, Medicare, that kind of thing. So, Graham, thank you for joining us today.
Yeah.
We appreciate it. He's all festive there with this tree in the background. Um, anyway, I guess without further ado, we will let you get started, Graham. I assume, I don't know if you want questions during, at the end, if it
I
matters.
would say let's if you have questions, definitely write them down, keep them in the back of your mind. I have no place to go, plenty of time to answer questions afterwards.
Yeah, you can
Great,
also use the
perfect.
chat feature if
Oh,
you just
yeah,
want to write down the question and just have us address
Perfect.
it after Graham's finished here. So feel free to use that feature.
Awesome.
it'd be great.
Well, thank you, Abby, Casey, the whole team at Euclid's Wealth Management for having us be a part of this conversation around Medicare. But most importantly, thank you all for joining in, taking some time out of your day to have this conversation. Normally, the only thing that you'll kind of find out in the wild when it comes to Medicare is this handbook. You can oftentimes find it in doctor's offices, which is called Medicare and You. If you've seen it, you'll know it's pretty thick. It clocks in at 128 pages and nearly 50,000 words. To give you an idea of how long that really is, a novel needs to have 50,000 words. So this is what the government gives you is basically a novel length handbook for you to make the very important and oftentimes confusing decision around when to take Medicare and what your choices are. So with the time that we have available today, what I'd like to do is unconfuse that a little bit. What we'll do is talk about original Medicare to start. How it is that you qualify, and then what original Medicare is, Parts A and Part B, what they're not, and what they cost. Then we'll talk about additional plans, additional types of insurance that you'll likely want to consider throughout retirement, Part D plans for medications, Medicare Advantage plans, which are also known as Part C, and Medicare Supplement plans, which are also sometimes called GAP or Medigap plans. And then we'll wrap up with the big when question. When it is that you need to enroll into Medicare to get the timing right and also to avoid any costly penalties. But up first with original Medicare, how you qualify is pretty easy, and it looks and feels a lot like Social Security. You have to work and pay your Medicare taxes for 40 quarters. Those quarters don't need to be in a row, you just need to have 40 of them all put together. That'll qualify you. If you yourself don't have those quarters, as long as you're currently married to someone that does, or if you've gone through a divorce, you were previously married to someone for 10 or more years, that'll qualify you. Generally, you need to be age 65 or older in order to first enroll. However, there's two instances where you could get in at a younger age. However, it involves Social Security disability insurance and specific illnesses. If you're on regular Social Security disability insurance for 24 consecutive months, you can then qualify for Medicare in the 25th month. And if any individuals have end-stage renal disease, which is kidney disease, or ALS, more commonly called Lou Gehrig's disease, once you qualify for SSDI with either of those two specific illnesses, you'll then immediately qualify for Medicare. There's no waiting period. And Medicare has a really big network. Almost every doctor you've ever met participates in the Medicare network. The ones that don't either have specialties that are not traditionally covered by Medicare, or they might be concierge doctors for the ultra wealthy, as an example. Part A is the first portion of original Medicare. And this is usually referred to as usually referred to as hospital insurance, but it covers a lot more than just going to the hospital. It can cover up to 100 days in a skilled nursing care facility after a qualifying stay in the hospital, inpatient nursing care, home health care, and hospice care as well. You'll notice in the parentheses, though, it says not long-term care or custodial care. If there's the chance you might have custodial care needs, that's basically help doing everyday activities, think like putting clothing on, going to the bathroom, Medicare is not going to cover that. And if you're considering any stays in long-term care facilities, depending on that facility, it may only cover a portion of any treatment that you could get and absolutely none of the room and board. And these facilities can be very, very expensive. So we'd want to make sure you're at least budgeting appropriately, or maybe seeking other forms of insurance that can help you offset the cost of stays in those facilities. Part A, in addition to being called hospital insurance, is usually referred to as premium free Medicare. And for most people, that's completely true. You will not pay a month over month cost or a premium for your Part A coverage. However, there's still cost for any of the treatment that you do get under Part A. As most individuals do experience this by going to the hospital, that's what I want to take a quick look at here. The first important factor to know is that you do need to be admitted as an inpatient. So you're not just at the emergency room or there overnight for observation, you need to be officially admitted as an inpatient. Once that happens, it sets off what's referred to as a benefit period. Benefit periods last for 60 days. So if I go to the hospital on January 1st, I get discharged 2 days later, and I go again in February, that's going to be inside one benefit period. But if it's January 1st, discharged, go again in September, two separate benefit periods. Once it opens, a deductible has to be paid. This year, that amount was $1,676. It's going up by a little over $100 next year. And that covers the first 60 days of your explicit hospitalization costs. If you're in the hospital for longer, there'll be more copays. Days 61 through 90, that copayment this year was $419. Next year, that's moving to $434. And if you're there even longer, then the copayment doubles. So this year, that amount was $838. If you're in the hospital for a very, very long period of time, 150 or more days, then you'll have to pay all the costs of your hospitalization. I have never met anyone in the hundreds of times I've done the seminar that wants to be in the hospital for 60, 90, let alone 150 days. And I sincerely hope that happens to absolutely none of us or anyone that we know. The second portion of original Medicare is Part B. And Part B is usually called medical or doctor's insurance. It covers outpatient services not specifically related to a hospitalization. So Part B can help cover preventative services that would be things like MRIs, CT scans, X-rays, mammograms, things of that nature. Emergency room visits are covered under Part B because that's not considered an inpatient setting, it's outpatient. So emergency rooms are Part B, along with any urgent care facilities you go to. Durable medical equipment is a big piece of this. That's going to be canes, walkers, wheelchairs, hospital beds, but it can be much more specific. It can be things like wearable insulin pumps or blood test meters. What qualifies as durable medical equipment runs on for pages and pages. And then in limited ways, Part B can help cover certain prescription drugs, select clinical research, and oftentimes combined with Part A, elements of mental health care. Unlike with Part A, there are premiums or month-over-month costs that you have to pay. They're non-negotiable for Part B. This year, these premiums started at $185, but could climb to nearly $630. Next year, that's going to $202.90 and $685. All of these increases is what's known as an IRMA. IRMA stands for Income Related Monthly Adjustment Amount. And although it sounds like my friendly Aunt Irma, it isn't, can be very, very expensive, and takes a lot of people by surprise. Here's the surprise factor. These premiums are based off of an individual or a couple's modified adjusted gross income and their tax filing status from 2 years earlier. So just as an example, let's just say I was retiring here in 2025, I was turning 65. They're looking back to when I was 63 and still working to determine what my premiums could be. So for a lot of folks, some of their highest earnings years are as they're leading up towards retirement, which could put them artificially in an increased Part B IRMA bracket. And a lot of folks have thought, that's the government, got to pay the piper. You may not have to, however. There's a form that you can use called SSA-44. So SSA 44. If you've had a major sustained life event where your income is going down moving forward relative to what it was leading up to enrolling into Medicare, you can let them know and they can prorate that down to the more appropriate level. What qualifies as a major sustained life change? The number one usage is what's called a work stoppage or reduction. I think we can just call that retirement, but also possibly going through a divorce, your spouse predeceases you, you get remarried, the loss of pension income, or the loss of an income producing property, not through a sale or transfer. All of that could apply. And there are three best practices around SSA 44. The first is to wait until you get the official notice from Medicare saying what your premium is going to be. A lot of times folks will try to do this in advance. Their information isn't in the system yet. A determination hasn't been made, so it can get lost or it can get basically lost completely and you have to refile it. So to make it as seamless as possible, you'd want to wait until you get the official notice. You may pay an elevated premium for a month or two. You'll get that money back. Second best practice is that this is per person, not per couple. So even if me and my wife were enrolling into Medicare on the same day, we get the notice on the same day, both of us need to fill out an SSA 44 form, even though we're filing jointly on our tax returns. And the third and last best practice is that this needs to be done for the first year we're on Medicare, along with the second year. Doing it once doesn't automatically translate over to the following year. There's also a bit of a surprise factor that comes up again well into retirement with these premiums. Because if certain actions take place that increases your modified adjusted gross income, you could see your Part B premiums increase 2 years later. Because they're always doing this 2-year look back review. For example, I could do Roth conversions. I could sell my primary residence. I can write off a certain amount of that gain, but if it's over the allowable amount, the rest of that gain gets included in there. The proceeds from a sale of a rental property, all of that gain gets included. Big capital gains in a year, having an inherited IRA, taking RMDs from your IRAs. All of these things could increase your modified adjusted gross income. And when it does, if it puts you over one of these brackets, increase your Part B premiums later. So this is definitely a conversation to have with the folks over at Euclid to make sure you're planning for any of the knock-on effects, or in some cases, being able to plan around them altogether. Because unfortunately, that SSA 44 form does not take care of those one-time or less frequent kind of big ticket events that increases your modified adjusted gross income. Aside from the Part B premiums, there's also just cost for the care that you get under Part B. There's a lowish deductible every year. This year, that amount was $257. Next year, it's moving up to $283. Once that deductible is paid, Medicare will pick up 80% of the approved cost of treatment, and we're on the hook for the remaining 20%. Approved cost, it's a bit of a tricky phrase, though. And that's because there's a lot of doctors out there that accept what's known as assignment. Assignment means whatever the Medicare approved amount is, that's the total billable cost. Some doctors don't accept assignment though, and they are legally allowed to charge a 15% or up to a 15% increase over that approved cost. So as you're enrolling in Medicare, particularly Medicare plus a gap plan, which we'll talk about in just a few minutes, it can literally pay to ask your doctors whether they accept assignment or not. So that way there's no surprise cost of treatment from the doctors that you want to see. And Medicare Part A and Part B, it's an enormous program. We have barely scratched the surface of all the different treatments and procedures it can help cover. But there is some everyday or routine healthcare that isn't. Routine dental, vision, and hearing, not going to be covered. Regular physical exams are not covered. You get one freebie, and unless it has to do with Alzheimer's or dementia screening, they're not going to cover it. Care outside the United States, unless it's a very specific emergency on the border of Canada where a Canadian hospital is closer than an American hospital, it's not going to cover that. So Part A and Part B to me is a bit like a base model car. Gets you rolling down the road, but doesn't have all of the features that you'll want for your healthcare and retirement. That's where additional insurance will come into play. The first type of additional plan I want to talk about is a Part D plan for medications. Even though this has the letter D attached to it, this isn't the US government. This is offered through private independent insurers. The reason why I want to bring this up first is because even if you are on 0 medications when you retire, the government requires you to have what they call creditable drug coverage in retirement. So you want to get a very basic plan that helps you check that box to avoid any penalties. Following that, you're going to want to make sure that any medications you're on matches up with the list of medications for the plan. That's what's called a plan's formulary. Formulary is just a fancy word that means list of medications. There are IRMAs for Part D plans as well, just a different formula, and premiums will vary plan by plan, area by area, formulary by formulary. And you'll want to review these plans each and every year. Even little changes could add up to big out-of-pocket expenses for you. Pharmacies could change network, medications could get more expensive, the formulary itself could change. So you want to make sure you do that review each year. That review period happens in the fall. It's October 15th through December 7th every year. So this just ended. That's what's known as the Medicare open enrollment period, also the annual election period or the annual enrollment period. How it is that we pay for Part D plans and the cost of medications used to be a lot more complicated, but it's gotten a lot more simple. If you have any friends or family that are a little bit older than you and they've been on Medicare for a while, they might have talked about how confusing the phases were, particularly something called the donut hole. The donut hole does not exist anymore, and now there's just 2 phases to move through. There's phase 1, which is an annual deductible phase. The government always sets an absolute top end amount this deductible could be. Next year, it's going to be $615. Some plans will have much lower or no deductibles, but still credit the full amount for you. Then you enter your regular co-insurance or co-payment phase. If a certain amount is spent in out-of-pocket costs, this year that amount was $2,000, next year it's moving to $2,100. If you cross that line in the sand, then you won't have to pay any more money for covered medications. But again, it's the key word. It does need to be a part of that plan's formulary. Following this, there's 2 general directions most folks will go once they're officially enrolled into Medicare Part A and Part B. They can go the Medicare Advantage path or the Medicare Supplement path. I'm going to start on the left-hand side where it says Medicare Advantage or Part C. Advantage is C, C is Advantage, they mean the same thing. If you're like me and you like watching reruns of Frasier at night, this is what Name Your Washed Up Celebrity is trying to sell you is a Medicare Advantage plan. What these do is privatize and replace Medicare. It becomes your healthcare. By and large, they look and feel a lot like the plans you're probably used to while you're working. They have a Part A and a Part B component, so hospital and a doctor's, and then they can have some other benefits as well. Many of these plans will include creditable drug coverage as part of their list of extra benefits, but it could be other things like gym memberships, the Silver Sneakers program. The different benefits will vary wildly plan by plan. The network will be different as well. It's not the Medicare network. It's going to be a network that's specific for the plan. Usually either a PPO, a paid provider organization, which has a defined local network, but also out of network pricing, or an HMO, which is very, very local, and that stands for Health Maintenance Organization. To see specialists, you may need to get referrals to do so. And there's also what's known as pre-authorization. Pre-authorization is a pre-approval process. If my doctor says I need something like knee surgery, it's not my doctor that said so that allows me to get that scheduled. I may need to get that pre-approved or pre-authorized beforehand and then see a doctor that's in network. If I go see a doctor with my Medicare Advantage plan, I don't use the red, white, and blue Medicare card. I use the card that comes from the insurer. And these are oftentimes referred to as premium free or low or no cost plans. However, that Part B premium we talked about before, including any IRMAs, you still have to pay that even though you're on a Medicare Advantage plan. And then you're going to have your regular deductibles and co-pays and coinsurance. So again, a Medicare Advantage plan is a privatization of Medicare. It's your healthcare under one big umbrella. On the other side is a Medicare supplement plan or a GAP plan. And this is the serious alphabet soup of Medicare. So if you're tired of letters, I apologize, more get thrown your way here. If you've ever heard of things like Plan F, G, or N, those are gap or supplement plans. As the name implies here, these fill in the gaps and supplements what original Medicare does not. So this works in partnership with original Medicare. You sign up for Part A and Part B, and then you can choose one of these gap letters. You do have to pay an additional premium for these plans. What do you get for that additional premium? It could pay the Part A deductible, could pay the Part B copayment, the overage for doctors that don't accept assignment. It can pay that. So it can help control a lot of out-of-pocket costs for more expensive or more frequent doctor's visits and procedures. It is a bit of a do-it-yourself method though, because it's A and B from the government, the gap letter you choose. You need your own standalone medication plan because they're not included here. And if things like dental, vision, and hearing are something that you'd like, you can also get your own insurance there or see there's a pay-as-you-go rate for those doctors. The network is Medicare. So even if you were to have a plan issued in Ohio, Indiana, or Kentucky, and you visit family in any other state and something happens, it'll absolutely be accepted because Medicare is the network. There's rarely referrals for specialists, and the incidence of pre-authorization is much lower. It's for very specific procedures. You do use your red, white, and blue Medicare card, along with the insurer that offers the supplement plans getting billed after Medicare. One of the catches, though, is that in most states, in order to have what's known as a guaranteed right of issuance, you have to pick a gap or supplement plan within 6 months of first enrolling into Medicare Part B. Inside that 6 month window, no questions asked, you have that policy written. Outside of it, you could go through medical underwriting. And what medical underwriting means is that they could have you run tests, go see doctors, fill out questionnaires, pre-existing conditions could be known. At worst, which is fairly uncommon, they can deny you the policy altogether. More likely, what they'll do is increase the premiums on a month-over-month basis. So this leads to the last big topic we have when you need to do this. There are 5 different enrollment periods with Medicare. We covered that open enrollment period a little bit, but the 2 that will matter the absolute most for you when you're getting started is either an initial enrollment period or a special enrollment period. So for the sake of time and your sanity, that's what we'll focus on here. The initial enrollment period of the IEP is a 7-month window that surrounds your 65th birth month. Starts 3 months before, it includes that entire month, and then it goes 3 months afterwards. What we need to know is, are you planning to continue working past 65? If you are, or you're covered by a working spouses group healthcare plan. As long as your company's plan, as long as your company and the plan through them or your spouse's company has more than 20 people, you do not have to enroll into Medicare at all. Neither Part A or Part B, there's nothing specific you need to do. You simply don't enroll into Medicare. However, if your company has less than 20 people, you're on COBRA benefits leading up to 65, or you're on retiree benefits, all of that insurance, no matter how good, no matter how expensive, pays secondary to Medicare. That means Medicare is your primary payer and primary biller. You would need to enroll during your initial enrollment period. If you didn't, you'd be charged what Medicare would normally cover, which is the bulk of the cost. If you're on marketplace-based plans, those are no longer valid past 65. You would need to enroll into Medicare and then make those other insurance decisions. One other consideration here is if you have an HSA because you're planning on working past 65 and you want to keep funding that. HSAs are health savings accounts. A lot of people are told or they're encouraged when you're 65, no matter what, you should enroll into Medicare. And that's good advice, but not always great advice. Here's why. If I'm planning on working past 65, I have my company's based healthcare, and I want to actively continue to contribute to an HSA. If I were to enroll into Part A, I'm then in violation of a whole bunch of IRS rules around high deductible healthcare plans, and I lose the tax deductible nature of that HSA, and there can be later tax penalties as well. So if having that HSA and continuing to fund it is important for me, I wouldn't want to enroll into Part A. If you don't have an HSA or your spouse is the one that's funding it, but you're not, you could enroll into Part A, no harm, no foul. If you did work past 65 or you were covered by a working spouses plan, but now that's ending, then you enter into what's known as a special enrollment period or an SEP. You can do this while you still have your insurance, usually 2 or 3 months out. Once you lose your coverage or you retire, whichever happens first, and this extends up to 8 months afterwards. Two other considerations here, though. The first involves that HSA to start. And that's because, for whatever reason, just with the special enrollment period, they will backdate your Part A coverage if you held off by 6 months. So let's just say I worked until I was 68 years old. I started this process in February. They're backdating my Part A by 6 months, which puts me into the prior year. So all I need to do is make sure that I stop funding my HSA at least 6 months beforehand or up until the allowable amount. So you can work with your HSA provider to get the timing done on that correctly once you know what your game plan is going to be. The other consideration is if you should have been on Part B, but you weren't. So folks that thought COBRA benefits counted, thought their company had more than 20 people, turns out there was only 18. For each full 12-month period, you should have been on Part B, but were not. Medicare charges what they call a surcharge, but it's really just a penalty. It is a 10% penalty that gets added onto your Part B premium each month for the rest of your life, no way to appeal. Two bits of good news about this, if there is such a thing as good news about penalties, is that it's only for full 12-month periods. So if I was less than a year, let's just say 6 months, I just wouldn't have had the right insurance at the right time, but I don't get a penalty. And if I was more than 12 months but less than 24, it's still only 10%. They're not prorating it for those extra months. And this is only ever based off of the starting Part B amount. So that 185 for this year, the 203 for next year, if you have an IRMA, that 10% isn't calculated off of that increased value. So that's a bit of good news in an otherwise not good news situation. I'm going to be pausing here in about 45 seconds and handing this back and over to Abby and Casey. But my ask of you is to start these conversations beforehand, before you're turning 65 or about to retire. We want to make sure that you're having a conversation with your spouse about what the plan is going to be, involving other family members as well, because they'll oftentimes be helping you out down the line. You'll want to work with a financial professional. I probably said the word cost 30 times in just about 30 minutes. Medicare is not cheap. The cost of healthcare in the United States rises faster historically than inflation. We want to make sure this is part and parcel of your financial plan. And lastly, you may choose to work with a local specialist or at least someone that's licensed in your state to help you identify the plan options that are available for you that you can also review on a year-over-year basis with them. They become part of your team. So I'm going to pause here, I'm going to take a sip of water. I'm going to hand this back on over to the folks over at Euclid's, but I'm happy to answer any questions that you folks have.
Great. Thank you, Graham. That was very informative. We appreciate all the information. A couple comments, just piggybacking right there on the back of what Graham said last. I know we've done these seminars before with our local partners, if you will, at Retirement, and they do a good job of you go to them before you're going to get on Medicare, or even every year when you're, when the enrollment period is, and say, hey, these are the medications I'm on. This is my situation. What should I do? And they look at all the different companies and insurance, providers, and who's covering what drugs and what would work best for you. We've had pretty good success for them case, I think. We've sent several people over there, well, more than several. We've sent a lot of people over there and have never heard anything bad back, only good positive things. And they've, I know they helped with Tim get his
I was
insurance.
gonna
I
say,
know they helped, my
we need
mom, I
some
just had my
license.
mom's checked, to be sure it was okay. That kind of thing. So I would recommend them. There's other companies around, so don't feel like you have to do Retirement, but certainly the bigger name around here, and they seem to do a good job. So that's something to keep in mind. The other thing, back just when you mentioned the IRMA situation and having a something happen where your premium goes up. That happened to my mom when my dad passed away. She got somehow, I don't even know how it worked out, but she got some kind of lump sum asset that was included in her income, and her premium then 2 years later was higher. So I filed my SSA 44, SSA 44, just saying that my dad had passed away. And I was shocked at how quickly they processed it and got my money back and changed the premium right then and there. So if you think you have one of those reasons, I would go ahead and file it. All I can say is no, right? I mean, there's certain reasons. Obviously, that was one of them that my dad had passed. But so keep that in mind if you're in that situation. I would definitely file that and see what happens. Okay, questions. We have any questions out there? I thought I saw something on the.
Do.
Yeah.
Yeah,
Okay,
in
what
the
do we got,
chats.
Case?
Susan asks, once you elect a Medigap plan, can you switch to a different gap plan next year without penalty?
So I'm going to answer this in two sections. The first section is going to be a yes and but. Um, so in general, yes, if you start with a Medigap plan and you say a year or 2 years later, I would like to switch to a Medigap plan, if you want to downgrade, it's a lot easier. So right now, something like Plan G is considered the most comprehensive. And if you wanted to go something with lesser coverage, like a Plan N, that's a lot easier. If you want to upshift, so if you wanted to go from something like a Plan N to a Plan G, that can be a little bit more challenging. They could again have you go through medical underwriting. Doesn't mean it's impossible, but it's a little bit harder to go from a lower coverage gap plan to a higher coverage gap plan than it is to go from a higher coverage gap plan to a lower coverage gap plan. The other kind of spur question that oftentimes comes out of that, which is, what if you started with one option and then wanted to go to another? Like if you started with an Advantage plan and then wanted to go from a gap plan, or if you wanted to go from a gap plan to an Advantage plan. If you want to go from an Advantage plan to a gap plan, again, that's going to be a little bit more challenging, particularly if it's after that 6 month Medigap open enrollment, because medical underwriting could come up. You do get something basically like a free look period with Medicare Advantage plans, where if you say, ooh, I don't think I picked the right Advantage plan, and you want to either choose a new Advantage plan or go to a gap plan, you have a window to do that. It's usually the first 3 months after selecting an Advantage plan. To go from Advantage to gap, very, very difficult. To go from gap to an Advantage is much easier. So I know I over answered that question, but I wanted to make sure that I covered all the different angles.
Thank you for that.
Next question is there such a thing as only using Medicare and not getting private
Hmm.
insurance?
Technically, yes. If you just want to have Medicare A and B and then get a medication plan that's creditable, you check the government's box. So I can't tell you not to go that direction, but it does mean that you may not have some of those additional benefits that come along with Advantage plans, as an example, or kind of the helping control more expensive out-of-pocket costs with gap plans. I'll just give you an example, because I've seen this in my own family several times. Knee surgeries cost around $50,000, give or take. If you just stay on original Medicare, you're going to be paying about $13,000 just as a starting point for that surgery. If you have an Advantage plan, there's always a maximum out of pocket. Next year, it's going to be, call it around $9,000. So that's the absolute top end. And with a gap plan, you might not be paying much or possibly, if any, costs for that surgery, but you are paying those additional premiums month over month. So while, yes, you can just do original Medicare, I haven't found too many people that just go that route because they'd like to have other benefits or be able to control more
Mhm.
expensive procedures down the line. So again, I know I over-answered that, but I never want to under-answer your questions.
That's a great answer. And I'll again use, unfortunately, my example. Before my dad passed, he was in the hospital for about 8 weeks, had two major surgeries, and the bill was $2 million. We paid nothing. We paid zero because of
Yeah.
the extra insurance. If we'd just been on
Yeah.
Medicare, I mean, it would have been less than $2 million, but it would have been very significant. So
Yes.
um,
That is a scary
I'm not
number.
exaggerating, and I don't, but that's what happened. So I would highly recommend um, some kind of additional insurance on that. That's would be my recommendation from personal experience. Anything else?
Yep. One last question in the chat. If you have a Medigap plan, does it carry over from year to year?
Yes. So if you choose a gap plan, that's just going to automatically cross over to the next year. Basically, the general guidance is once you have a gap plan, you choose the best one that you think is going to make most sense for the long term. And unless something structural happens to it, you stick with it. And I say that because for a long, long time, plan letter F was considered the best one out there. Plan F stopped being available to new enrollees in 2020. So folks that were on Plan F, because this is insurance and we're starting to see a shrinking pool of people in Plan F, they're seeing their premiums go up a little bit. So some of those folks are considering switching to a Plan G. So they are downshifting, but there's just a little difference between an F and a G. The only difference is that F covers the Part B deductible and G does not. So those folks are considering shifting from that just because they're seeing their premiums in certain areas tend to go up a little bit more than they would like it to. But in general, it just kind of carries over year to year. However, the D plan or the medication plan that you have in conjunction with your GAP plan, that can carry over, but you'd want to still review it just to see if any changes are going to affect you in any meaningful way.
Right. Does anybody have any questions they want to vocalize out loud or put into the chat box? Please let us know before we bid Graham goodbye. Again, I just do want to mention, and I don't get anything from RetireMed or anything like that, but they have been, if you're about to get on Medicare, they'd be worth a consultation with them. Tell them, what your ailments are, what your medications are, that kind of thing, and they can find the best plan for you and the best setup, whether it would be a gap plan or if it would be Medicare Advantage or whatever it would happen to be. They can give you your options, show you the benefits, costs, that kind of thing. So,
Hey,
certainly,
Abby, this
yes.
is this is this is Tim.
Hi, Tim.
Um, would you mind saying what kind of plan covered that $2 million? Was it an Advantage or a Gap or what?
I'm pretty sure they were Advantage. I don't know. I'll be
You
honest
don't
with you.
know.
I don't know that part. I know we had a
Without
Humana card.
knowing,
It was Humana. I can tell you
okay,
that. And yeah,
Okay.
either one would definitely reduce costs with a $2
yeah.
million bill.
It was, I just kept waiting to get a bill in the mail, like you owe at least something. I never did. I don't know why. I don't know what kind of
It
premiums they were paying, but
it does
whatever.
seem as though that might be a gap plan, but without knowing all the
Yeah.
details, either one is going to be a cost savings
Yeah.
over
I'm
a
not sure
massive
how
bill
I
like
would
that.
know. Is there a way I would know that? Like, without
Um,
knowing anything, just having the cards, and I don't have the cards anymore, but
yeah.
I just know it was Humana. Let's just put it that way. It was Humana. So,
Hey,
Okay.
Abby,
Thank you.
yes. Yes, Susan.
I
You're
have a
welcome.
question. So if I get, suppose, Plan G through one provider, this for 2026, is it easy or hard to switch to a new G provider
Oh,
for
yeah,
2027?
if you want to switch insurers, but it's the same G plan, you can do that. So you're just choosing a different provider of the same gap plan, so you are able to do that. So as an example, there's even though the letters are all federally standardized, with the exception of Minnesota, Wisconsin, or Massachusetts, they have their own state-specific plans. But other than that, every other state adheres to the federal standards. But there could be cost differences for those different insurers. So if for some reason you were sold a very expensive Plan G and you found that there is another provider that could save you $25, $30 a month, it's the exact same plan, you could do that. That's not a problem. Someone like the agents that Abby and Casey are talking about, they might be able to let you know where if there's a slight cost difference between one carrier over another, if there's a reason to choose that slightly more expensive one. Let's just say it's an additional $5 or $10 a month. So nothing, crazy, but you might have better customer service or they have a better billing network or something along those lines. There might still be a reason for that, but there's a and there are some smaller more regional carriers or providers that might just be more expensive, and you could say, oh, I like them because they are also where I get my health insurance and my life insurance, but um, their gap plans could be very, very expensive. You could then switch to one of the lesser expensive options as long as it's either the same letter or one that offers less coverage. Hope that
Mhm.
helps. Hope that helps,
Okay,
Susan.
thank you.
Yeah.
And I just want to go back into what you're saying there. I just want to make sure that I think I understand this, and hopefully people
Yeah.
on the phone. The different letters, like you said, are general, so or across the country except for those
Yep.
states. So like a G plan covers these 100 things, and a G plan at Humana and a G plan at United Healthcare or whatever, they cover the same things. The cost just there you go.
Yep.
Cost just might be a little different. Is that fair to say?
Correct.
Okay.
Yep. So, I if it's rather than calling out insurers, I don't want anyone to have a bad idea over one insurer or whatever. So it's insurer number one and insurer number two,
Yes.
and it's a Plan G. What you see here with Plan G, that is across the board, state to state, insurance provider by insurance provider. One might be they could just have a general cost difference on a month over month basis. And then I know we're starting to like get into the weeds here, but they can also rate them, which is how they determine the premiums, usually in two different ways. What they call attained age, which means it starts off when you're 65 at a lower price point, and as you age up, it goes up a little bit each year. Or they have what's just called age rated, which means everyone that's age 65 locks in a lower price point than someone who's first getting in at age 70. So that could also be a bit of a difference. So let's just say there's an age difference between you and your spouse, and you're both enrolling into Medicare at the same time, you're both choosing a Plan G. You might have different premiums just based upon the age difference between the two of you. I know that's convoluted. I promise when you sit down with the folks that they're talking about, they'll be able to sketch this out a lot more.
And just to kind of go more on that point, your spouse and you can have G plans, but have two different providers.
Yes, or one person could go with Advantage, one person goes with G, or you could have two different Advantage plans. It's not a one size fits all scenario. Everybody can make their own different decisions based upon what they think is best.
And I do think a lot of that has to do with like the drug coverage and stuff too, right? Like which
Definitely I'm not gonna say it was ever not important, but I think it's become even more important as medications have gotten very, very pricey.
Yep. Okay. Anybody else? Well, it has been a pleasure to see your names, if not your faces for sure, and catch up with all of you. So thank you for joining us. Graham, thank you so much. We really appreciate the insight and the information. If anyone has any follow-up questions or whatever, please feel free to reach out to us. For those of you on the line who are retiring in a couple weeks, congratulations. And then again, yeah, if you want us to continue to do seminars with us, send me your personal email and I'll add you to the list. All right. Well, everybody have a great holiday. Happy New Year to everyone. I hope 2026 is good to everybody, and we will catch up soon.
Thank you, Abby.
Thank you. Bye.
Thank you.
Thanks, Abby.
Bye.
Thanks, Casey.
Thank you.